Well, thank you everybody for joining us. It's really exciting to build these bridges between research community and the clinical community. And it's our pleasure to introduce Dr. Halim Adeli from Hamad Medical Corporation. So Dr. Adeli is a consultant neurologist and a neurophysiologist, with emphasis on movement disorders at the Faculty of Medicine in the adult neurology program at HMC. So a little background on Dr. Golem. He trained at HMC under the Arab Board of Internal Medicine, and then continued his training in Canada, where he trained in general neurology and movement disorders at University of McGill, and then at University of Toronto. And then he further trained in neurophysiology in Hanover, Germany. And I think you'll see from his presentation that he's an expert in looking at the clinical issues of movement disorders, and he's certainly takes a lead role in training junior fellows and residents and interns in his area of expertise. And so we're fortunate to have Dr. Golem present to us on his important work in movement disorders. And you can see his title is going to be focused mostly, I guess, on Parkinson's disease, but I look forward to hearing you, Dr. Golem. So we don't see your face, Dr. Golem, but let's shift over and hopefully we can see. I think Reem has a few bookkeeping things here. Maybe I'm supposed to say this. We'll leave some time at the end of the presentation for some questions and answers. So if you can type in your questions and I'll direct them to Dr. Golem at the end. And I think this might be recorded. I'm not sure. So you see that you can read the indication. Here's a few tips on how to use your devices, which I don't need to read to you. So anything else you want to show, Reem? If not, there's Dr. Golem. So it's great. We can see you very nicely, Dr. Golem. So if you want to, I'm going to go to mute and shut off my video in a minute, but you want to see, you can share your screen. Not seeing it yet. I should mention that Dr. Golem has been a good friend of QBRI for quite some time. He actually spends time at QBRI helping us on validating some of our molecular biomarkers for Parkinson's disease. I can see your pointers moving around, Dr. Golem, but we don't see the presentation. Is it on share for the, there it is. All right.
Oh, you see it now?
Yes, I do. So if you go to full slideshow, then I'll turn it over to you. Okay. All right. It's all yours, Dr. Golem. Okay. Thank you for coming.
Thank you very much. Thank you very much for the introduction and this great opportunity to present this loved topic. So what we will try to do is to cover this topic in 40 to 45 minutes, and then we'll wait for your questions. And first, before anything, in relation to this presentation, I have no conflict of interest need to be disclosed. So we are going through certain objective definitions, etiology and risk factors, pathology, clinical features, investigation, differential diagnosis, and then a touch on management. So before we dive into the Parkinson disease, let's talk a little bit about what do we mean by movement disorder. If we are talking about movement disorder, it's not always about the basal ganglia or about the Parkinson disease. The most, one of the part of this movement disorder is the cerebellar disease. Why we have to know it for this topic? Because we have something called Parkinson plus, where not only the basal ganglia, also there is one more organ is involved. So then it comes the basal ganglia that we will talk about it, and then the corticospinal tract, which is responsible for the movement that we do. So these two will give you ataxia in the cerebellar disease. Let me just remove this one higher, okay. And the corticospinal tract gives you spasticity, which is like with the patient describe it as a stiff limb or stiff legs. Ataxia, that they're past pointing things, like whenever they want to do anything, they will be like clumsy type of thing. They will be imbalanced. So These are some of the features that you see in spasticity here and in cerebellar disease in the other side. So let's go back to the real topic today, which we are talking about is the basal ganglia. And when we talk about basal ganglia, there are some definitions they come up. We call it hypokinesia, less of movement, hyperkinesia, more of the movement, and there is something called motor and sensory behavior. Why I will give you some definitions about this motor and sensory, because these are so common referrals that we get and the people take them as a neurologic or as a disease. There are few examples of this one. One of them is the OCD or the compulsion, where somebody will have this obsession for perfection or anxiety that cannot be relieved until they do things like repeatedly. And that's not like the movement disorder that we deal with. It's for psychiatry. Then the mannerism, which is like people carry out a normal task with a peculiar, just to draw attention, like drinking water or something. And always I joke with my students, you see this in the Medina Central area where like people sit outside with this fancy 2.5 million cars and drink coffee, and you just observe them, you see this, how they drink the coffee or how they look at people, etc. Habits are the things that you do when you're bored or anxious sitting, and these are the things. And then there is something called stereotypies, which we see in cognitively impaired people or sensory deprived people, where they do certain like repetitive movement, and they should not be suppressed or treated unless it's really affecting the sleep or affecting the caregivers. So we take these two out of our ways, the mannerism and compulsion. We'll go back to the real topic here, which we said about hypokinesia is a part of the basal ganglia problem. Akinesia and rigidity. Akinesia is no movement. Rigidity is stiffness of the joint. You cannot move the joint freely. Hyperkinesia, there are so many other names are there. Tremor, myoclonus, dystonia, chorea, tics. Why I will put one slide to know these things, as I say, again, these are what we have to always find if they are associated with Parkinson's disease or not, because it will take us out of idiopathic Parkinson's disease. So this is a very simplistic type of slide, but it covers most of the things in movement disorder. Like if somebody comes with any abnormal movement, please try to look at the movement. Is it rhythmic? Don't know if you see my hand, like it's like a rhythmic type of thing. The fro and cro, like it's both are symmetrical. They are all like, they will do like the hands like this. It's like a rhythmic type of thing, like a clock ticking. If it's rhythmic, that makes your life easier, and you could name it a tremor. If it's not rhythmic, then the first thing you have to look for is it's sustained. It's like, for example, like it's movement, but it's going to posture, like going to take into certain posture. That's what you're talking about is dystonia. The difference between dystonia and tremor is agonist and antagonist muscles alternate. One contracts, the other relax. In dystonia, no, they all contract at the same time. And who's stronger will take the lead for sure. Like we know that supinator muscles are stronger, flexor in the upper limbs are stronger, so they will take the lead. So that's why the posture will be with the stronger muscles in dystonia. So other part of non-rhythmic movement, if it's not sustained, non-sustained, what we are thinking of, then if it's slow, like something like writhing type of movement, we call it athetosis, and we see it in the distal part of the hands. It will be like this, the arms are athetotic type of movement. These are slow, non-sustained, non-rhythmic. Then if it's rapid, then ask the patient, is it suppressible? It's a rapid vocal tic or rapid motor tic. Anything suppressible or the patient can manipulate, and then you add some other features into it. Is it building up with a tension? Is it there is any relief after doing it? Then you're talking about tics. What if it's not suppressible? Then you are dealing with the other resting movement disorders like myoclonus, which is a shock-like syndrome, or chorea, which is a dance-like. And the brother of chorea is hemiplegismus, because it's a proximal. Hemiplegismus would be like abnormal, like movement dance-like in the proximal muscles, while chorea will be dance type of movement distally. So by doing this division of the movement disorder, we cover almost everything clinically. And it's a simple and easy way to do. So we'll go back again to the real slide there. So now we know where is the Parkinson disease we could fit it in. So I put the Parkinson disease here, and I'm talking about idiopathic Parkinson disease. What does Parkinson disease take? It takes two parts. Most of the places that you go, they always talk about Parkinson disease as a hypokinetic, low movement, akinesia, and rigidity. But Parkinson also take one part of it from hyperkinesia, which is tremor. What is then Parkinson plus? Parkinson plus, if you start to include these two other guys that we talked about them, ataxia or spasticity, so you moved out completely from the basal ganglia. The mnemonic trap makes Parkinson's disease a little bit easier, and I like it for idiopathic Parkinson's disease because the P, which represent postural instability, is toward the end. Because so many times we have referral of the cases as a Parkinson's disease, and they start with a postural instability. That will put a question mark. This is one of the big red flags that you have to keep in mind. If somebody is coming with a history of slowing, and then he's falling frequently from the beginning of the year, of the beginning of the diagnosis, then you have to think differently of a different diagnosis. What are the other features of Parkinson's disease? Tremor, rigidity, akinesia. But akinesia is the most important one. It's A level, A sign, whatever. Just remember it. A is the first thing. You need to be slow to think of Parkinsonism. Adding to it the flavor of tremor. The tremor is usually at rest, meaning when the hands are resting, not trying to hold something, not like being put in a posture. And we'll talk about a little bit more later. Rigidity, we said again, it's the joint is not able to move anymore freely. If you're trying to move a joint, it will be difficult. It's as if there is like a lead pipe or something like resisting you. And if there is a tremor in it, it will be like a cogwheel moving. So that's a rigidity, resistant to passive movement of the joint. We'll go back to our lines about definition first. What do we mean by Parkinson's disease? It's a chronic progressive disorder caused by degenerative loss of dopaminergic neuron in the brain. Dopaminergic neurons are lost, and it's one thing to remember, it's a clinically also important. It's asymmetric. It's one side. Anytime you have both sides, please put the red flag up that you're dealing with something else. And then there is a clear, and we say dramatic, response to and sustained to dopaminergic treatment. If the patient is not showing this response, again, it's like one of the Parkinson plus, or you're dealing with some of the differential that we will talk about it. So asymmetric, clear, and dramatic response, and sustained response. Before, was named as a paralysis agitans by James Parkinson, who was doing an essay on a shaking palsy disease in 1817. Later on, by Professor Charcot, was named Parkinson disease. We thought once that it's a result of industrial revolution. But looking into the literature, we found that the Indian described it 4,500 years ago under a name called Kampa Vata. Kampa is a shaking and Vata is a lack of muscular movement. So, and they treated it with a plant called mucuna. And this one is found later on to have levodopa in it. So it's much older than the Industrial Revolution. Epidemiology of it, and as we see, the numbers are going high and high. Prevalence is like 0.3% worldwide. This is in a meta-analysis of 47 studies. And incidence is around 8 to 18.6 per every 100,000 per year. Male are more than female affected. And the issue of young onset Parkinson disease, it comes up again, why we focus on the diagnosis of the young onset below 40. One, because of this social economic burden in it, because most of these people are still in the productive life working. Second, these are the ones have more of a what we will describe non-motor function. You may cure their motor slowness, but there are some non-motor like anxiety, embarrassment, isolation, depression, and these are really much harder to treat, and these are the more important to focus on. And also the pathology-wise, as we go younger, there is something called Lewy body disease, goes less in the brain. Etiology and risk factor. So there are lots of these causes mentioned, and we'll talk about them later in more details. One thing here will catch your eyes that there is mentioned that decreased incidence of smoking. I have a comment about that one because caffeine and those ones, no problem, increase their dairy product, dietary product, etc. They are okay. But for smoking, we have to remember that a smoker do not live to the PD onset at 65. And the smokers have so many other issues, especially in this area part of the world. You find them at 50, 55 years old, and they have this heart and problems, angina, myocardial infarction, heart failure. They have, for example, the kidney, or etc., etc. So they will be much more busy with other things, or they don't live. So I doubt this association, although they are putting in more and more into literature that cigarette smoking is a protective. So digging deep into those risk factors, these are still inconclusive evidence. Like, for example, if somebody has like a traumatic brain injury, like Muhammad Ali Clay, who was like a boxer and had this Parkinson disease, and sunlight or derived vitamin D. So history of midlife migraine, urban area, or living in a rural area, farming, or being exposed to pesticides, high dietary iron treatment, excess body weight, type 2 diabetes, and metabolic syndromes, low muscle strength. This is lower muscle strength and late adolescence, melanoma, and prostate cancers. As I said, these are linked, are more and more like risk and etiology, but it's not confirmed totally. So it's just to keep them in mind. The other etiologies are genetics for sure. And genetics, they are like any patient you have below age of 50, please think of it, and we have lots of genetic analysis. They are under autosomal dominant, autosomal recessive, and X-linked. And there are like a long list of them. It's not, the time will not allow us today to go through these ones. So anytime you have a Parkinson disease below 50 years of old, please, and especially there is one disease called Wilson disease. You don't need to do genetic testing on this one. You do the copper and ceruloplasmin, some blood test and urine test, and you could diagnose it, and it's curable if you diagnose it early. Pathology, it's neuronal loss, particularly and typically in the substantia nigra, as well as the pontine lucus coeruleus. Pontine lucus coeruleus is related to memory, related to balance issues. Remember this substantia nigra and its connection here in the midbrain. It's the only proven place if it's hit by a stroke or hemorrhage that to cause vascular Parkinson disease that we will talk about later. So one more thing to know, that once you have the motor system symptoms happening or showing on the patient, keep in mind that you lost almost 60% of your dopaminergic neurons in substantia nigra compacta. And that could be one of the reasons why some of the prophylactic treatment that's suggested to help, they may not help at this point. So one thing to know, that we do find that in a volumetric MRIs, there are some temporal lobe atrophy, but not all of them, they had also memory, they had memory issues with that. So this is again to make it, to simplify it more, that's the cut we take here, and this is the midbrain here, and we see the normal substantia nigra here in the normal brain, and we see what happens with Parkinson disease, that the pigmentation is lost. And this is like the features that the patient will take. That's somebody will say like, okay, rest tremor, but he's walking. Yes, when you're walking, your hands or your arm are resting. So that's the rest tremor that you see. Or if you put them in the lab when you sit down or you lie flat. So, and then the posture and the shortest steps and these things, we'll talk about it later. This is the pathology. Loss of in the substantia nigra and neuronal loss and degeneration. And this is the Lewy body disease that we see. And again, this is the actual picture of it. Like, as you see, like this is the normal one. And then when it's lost, what do they look like? Totally, the pigmentation is gone. Lewy body, just few words about it. It's not specific for Parkinson disease. You could see it in other amyloid diseases like Alzheimer's disease and amyloid, sorry. And also you see it in other accumulation diseases like ion accumulation or corticobasal degeneration or progressive supranuclear palsy. So it's not specific for Lewy body disease. And this is a slide I usually put it for the students. And this is the easier way, like if they are going to the pathology lab, to know if they are looking for Lewy body disease, like just to say like, is it intracellular or extra, and etc. Some of the feature, if the halo is like surrounding the body or not. So this is very simplification for the students. Was that pathology enough? No, actually somebody started to challenge that pathology by under Brack they questioned that pathology, that they mentioned that the pathology starts lower in the brainstem or the lower medulla and in the olfactory bulb, and builds up, and they classify it to like 6 stages. 1 and 2, they put it as a pre-symptomatic part, and where the person will lose the sense of a smell. So, and that's like a very simple test that we could do in any person that comes with depression, with a brain behavior disorder, for example, acting their dreams. They start to have like acting, or they have like unexplained depression. These are, we call them all like a premonitory or pre-symptoms in the pre-symptomatic era. And this is the olfactory testing is one of the tests that we could rely on and do it. In stage 3 and 4, where the classic, the substantia nigra things happens. Then in the stage 5 and 6, the more involvement of the hemisphere. And this is the way it goes. REM behavior disorder, then the mood, and then the motor comes later. Why that was not like, we are not happy with it clinically, because it does not address the asymmetry that we talk about. Because clinically, we always see Parkinson's disease asymmetric. It starts in one side, and then they go to the other side. So this will take us to this slide to know again the prodromal, the early sign here, like the REM behavior sleep. We are talking, when we are asleep, the tone of the muscles goes to sleep also. That's why you don't act your dream. But in people with Parkinson's disease, they will have this REM behavior disorder that the tone will not go away. So you will act your dream. So you will hit your spouse, you will break something, sometimes you move. So these are one of the things that when they start to report it, it should like raise a red flags, and we should do also this anosmic or smell test. Depression, constipation, anxiety, all these things, and then it will take time till we go to the real features like excessive daytime, and then the motor symptom will come up. Again, why this is important, since we are having more and more researches and looking for early diagnosis of biomarkers, we are always focusing here. So how do you target these people? Either to bring the people like they have these symptoms, or relatives of Parkinson's disease patients. So is it just, and that's a no, actually, these are really a big challenge as the disease progress also. Because as I mentioned earlier, this is one of the things that the motor symptoms could improve with the treatment, and these ones may lag behind. And so many times also, these are being sent to psychiatry without maximizing their their anti-Parkinson treatment. So why? Because he will feel depressed in between the doses. So that will give you a hint. It's a symptoms of a Parkinson. Your dopamine therapy is going down. What you should add to make the doses more frequent, or add an extra dose in between. Anxiety, for example, they may have like anxiety, but not all the time. When the medicine is kicking in the morning, I'm okay, I have no, but I will become anxious, afraid for no reason or something before the next dose. So we keep this in mind, because really they are disabling symptoms, especially in younger generation. So these are more pictures to memorize what we are talking about. And this is again about the biomarker. And we have some of the tests like a PET scan or DAT scan. If we are thinking that to help us in diagnosis, they could. The pathophysiology, it's easy to understand if we took it in a cartoonic type of thing. So let's consider the cerebral cortex here. Or it's like the father, and these are the kids, or like this is the president of a country, as I mentioned, and this is the thalamus, which is the prime minister. The president always gives like a stimulant to the people here down, with a green means like allow them to do, and a good stimulant money-wise, support, positions, work, etc. And they expect a good feedback from the thalamus to continue. If they based on their stimulation on the thalamus to tell them how the people are doing. So unfortunately here in the people, sometimes if they are dealing with some bad population of the people, they receive a stimulation, but they inhibit the people under them. Why is that? We will see from here. We have, this is a globus pallidus externa, and this is globus pallidus interna, which is part of the basal ganglia. Both are suppressed, but both they do different works. The externa suppresses the subthalamic nuclei. The subthalamic nuclei, if it's not suppressed, then it will stimulate the GPI. It is like another stimulation for the GPI. Why we are the striatum is suppressing it, and why we do not want the stimulation for the subthalamic nuclei. As we see, the job of the GPI and substantia nigra reticulata, the job of it is to suppress the thalamus. What happens if they suppress the thalamus? The thalamus will not work and will not give the feedback to the cortex, so it will not function again. So what do we need here? If we leave it this way, it's a sort of balance thing. We need something to favor, to block this one. What we do, the substantia nigra compacta comes in, facilitate the D1 receptor and inhibit the D2. And what this will do, as you see, the D1 inhibition of the GPI or globus pallidus externa and substantia nigra reticulata will be much more. And at the same time, the inhibition of GPE is less because it's doing it's a different job. So what happened? The function of it will maximize. And what happened? This will kill its stimulatory to the GPI. So what happened? This guy or this gentleman, GPI, is not like having no stimulation and having more suppression. What will happen? You're blocking the suppression of the thalamus, and this will give a good feedback to the cortex. The cortex again will start. So you'll move. The movement will be normal. And when we talk about the movement of the basal ganglia, we are talking the initiation of the movement and how fast to initiate it. And we are talking about the movement that you need while you are asleep, or you learn it while like driving, etc. And we are talking about the movement that you coordinate the proximal with distal, like when you're typing. You will not type like a robot like this and sitting typing the fingers. No, there is a coordination of proximal and distal, and there's also the face type of thing. So, and again, and the order will go from the cortex to the brainstem and spinal cord. They continue to continue the job. So this is for the normal brain. What about the Parkinson disease? As we see here, I put the Parkinson disease. So the normal president is giving the stimulation and money to the people the same way. But we have one problem. We have this substantia nigra compacta is diseased or dying, or 60% is lost. So there is no stimulation to D1 and no suppression to D2. So what happens? Less of suppression goes to the GPI and then more suppression to GPI. So it's giving you the opposite effect. So what happened? So you almost totally, there is the GPE is killed and no function on it. So this substantia subthalamic nuclei will stimulate strongly. At the same time, they have a less inhibition. So what they do, they very strongly suppress the thalamus, and the thalamus response to the cortex is less. So there will be less movement. So again, as you see the arrow, this is like a kind of a brief or like a kind of simplification how the Parkinson disease could function or could affect our brain. We finished with the definition, etiology, and pathology, and now we are doing two clinical features. As we said, there are several ones, but the most important thing is the bradykinesia or akinesia, and remember it from the mnemonic trap A, it's the A symptoms. So bradykinesia, what are we talking about the bradykinesia? It's difficulty initiating movement. It's reduced spontaneous blinking that usually we blink 10 to 20 times, and these people will be like staring, to be like a mask face. And then facial immobility, there is no expression in the face. And there is like a poor, like alternating movement or tapping with the fingers or pinching or rounding or also tapping the feet. But one thing to remember that here also we differentiate between Parkinson disease and Parkinson plus. For example, if I see my hand, I will ask him to do the rapid movement of the hands, opening and closing. In Parkinson disease, they go slower and smaller. We call it brady and hypokinesia. Slower and hypo, smaller. And if they just are brady, then we think about Parkinson plus syndrome. So this is the bradykinesia we talked about, and then we talk about resting tremor, and we said it's a type of thing, conception of people. They say how the patient will have tremor while he's walking, because when you're walking, your hand is dangling and it's at rest. You want to be more accurate, ask the patient to lie flat on bed and put the hands next to him and distract him. Make him like think of any subtraction of numbers or etc., and then you will see the tremor. One thing that should not be confused in the resting tremor of Parkinson disease, that sometimes it could come with a posture when you ask them to put the posture, the arm like this up, the beginning it's not there, but then it starts to re-emerge again, and that we call it re-emergent tremor. because the posture already stabilized, and then you are seeing the wrist tremor introducing itself. So you put up, it's not coming up, and then it'll start to tremor. So it's we call it a pin ruling tremor. It's then arm and legs, and also jaw and the tongue, and then diminished on action, etc. These are the features of it. And this is a little bit difficult for you, but these are the sides of the tremor and how we use it for differential diagnosis. I'll keep it there, but it's difficult to go over it all. So rigidity, simply to simplify it here, you are moving the joint. It's movement across the joint. It will be very hard. It's like, yes, I'm in a lecture. Yeah. Usually it's like a lead pipe, like when you're like bending a lead pipe. But if there is also tremor in top of it, you will feel like it's a cogwheeling type of thing. We call it a cogwheeling of Parkinson's disease. So then posture and instability, and as I mentioned, the mnemonic trap has the P toward the end, and that makes me happy because we should not see it early. So loss of postural effects start difficulty in turn, like usually at the beginning when they start in a few years, they will tell you that when I turn to the side of the weakness, the asymmetric side, they have a difficult turning or turn in block, like to go step by step. Then they will have this, what we call it, postural stability, as we stand behind them and we'll try to pull them backward. They are allowed to take 1, 2, or 3 steps, but they should not fall like a block, like on you. And as I said again and repeat, this should not be early in the course. The gait itself, it's like as we see that it's a stooping posture, it's like a tremor, and they're having this decreased arm swing. And then we look at the steps. These are the feet here. Look, the clearance of the tip of the toe from the heel here. In Parkinson, you will not see that. As they progress, this will come closer and closer. There will be no clearing. They will be almost equal next to each other. Plus, this distance also will be like a smaller, so it's a small base. And also always notice the tip of the foot here. It will be inward directed or straight. It's not outside. Why? If it's outside, we use it for other diagnoses. I will tell you later on. Like the foot are not diverted outside when they walk, and it's not separate from each other. They will come closer to each other and will be very small steps. A speech will be monotonous, will be a slight dysarthric type, and it will be like a foreign type of speaker, like just learn the language. They cannot increase the tone, and it will be hypophonic also, very, very soft voice, and this will be noticed by the family. Cognitive wise, we used to say there's no cognitive impairment, but there is 1/3 of the patient they may use, but it will be specifically with what we used to call as a subcortical dementia. It's like executive functions. It's what you do, like the planning, decision maker, shifting between tasks, etc. And depression is part of it. One thing is really important also, if you have a patient with Parkinson's disease and he's not responding to treatment, most of the time think about this GI problem that they have, especially that they have the H. pylori infection, and these should be treated because it affects the absorption. But one of the features of Parkinson's disease, where they have this dysphagia, heartburn, or weight loss, graysy skin, micrography, of course, is one of the other features. So there is other ways of scaling or grading Parkinson's disease. We have, for example, Hohen and Yahr. It's like a unilateral when it's one-sided, and it will be bilateral when they start to involve the other side, but still they are dependent. And then when it's like this, a little bit of postural stability or something that may have, then they will be like 3. And once they started to use the walker or some help, they will be 4. And once they are wheelchair, will be 5. So these are the more like of the features. So we will talk about some of the supportive criteria for, and this is really important to apply for every patient that you see and you're thinking it's a Parkinson's disease. We mentioned the patient should show clear response to levodopa or a clear response to dopaminergic treatment. And this is like measured. We have something called UPDRS part 3. It's a motor function. We do certain type of movement, and they will have to show like minimum 30% of improvement on it. Or sometimes some people also, because they don't have this facility, also they base on subjective treatment by the patient. So one more thing, in the course of the disease, in a couple of years, a few years, they start to have what we call dyskinesia, extra type of movement. Like they will have, instead of being slow, they will start to show like some abnormal movement. This is also one of the features that it's in favor of Parkinson's disease. Wrist tremor, especially, it's unilateral. That's one of the features, but it's not happens in everybody. 70%. We have a tremor dominant Parkinson's disease and has a better prognosis for response to treatment, but they are up to 70% of the cases, and it's unilateral. Once it's or bilateral, you think of so many other causes, including medication-induced, etc. The presence of either olfactory loss or cardiac testing also, it's one of the things that we used to do, and recently there are some argument about the MIBG that it could be helpful or not, but still we use it if we are looking for supportive evidence. So red flags, definitely these should be always kept in mind. If you have a rapid progressive gait in 5 years, somebody is showing more involvement of the gait and he's wheelchair seated, so please think of something else. Progressive supranuclear palsy, normal pressure hydrocephalus, etc., etc. A complete or absence of progression of symptoms of signs over 5 years, like they are stable in treatment. I mean, could be, I've seen cases like this, but keep in mind that you may not be dealing with Parkinson's, there's something else. Bulbar involvement, like they have dysphonia or dysarthria, or they have this voice issues, and also requiring nasogastric feeding, again within the first 5 years. These also should raise a suspicion that you're dealing with something that it's not idiopathic Parkinson's disease. Respiratory problem at night or inspiratory side as well. Then if you have severe autonomic features, like for example, whenever they stand up, they feel lightheaded, and you measure the blood pressure, you see that there is a systolic 30 and diastolic 15 is dropping like down. So, and of course you have to rule out dehydration, especially here in Qatar, because people don't drink much, or if he's taking any of the antihistamine or any like a treatment that causing him this pseudo dehydration type, or medication wise, like for blood pressure. Rule out these things, and then if it is like significant, then you have to think of the diagnosis that it's a differential or different diagnosis than idiopathic Parkinson's disease. Severe urinary retention, especially if there is no prostate problem. And then again, in the 5 years also gives like a chance that it's a multiple system atrophy. It's a Parkinson plus. And recurrent more than once, we emphasize on the falls that they may have like balance issues. And here it's also, they go down less than 5 years. It's within 3 years if you have recurrent falls. But please make sure that it's not related to inner ear problem or other viral type of flu or infection or something. So some of the posture of the head, it's like anterior collis, the head like goes frontally flexing, or contraction of the limbs and these things. Dystonia, or the feature of contraction of the limbs, we see it more as the patient is younger, and these are like the feature, we'll not see it in the older. Or if we see it in the older, you think of cortico-basal degeneration, as they have like it's a Parkinson plus, and they will have this dystonic type of posturing. We have like, I remember 10 of the, yes, we have absence of any of the common non-motor features. Somebody has only just motor and no non-motors, like no depression, no REM behavior problem, no sleep like issue, no nothing. So keep in mind that you are dealing with some vascular type of thing affecting the brain. Bilateral symmetric Parkinsonism, as in medication induced, etc. Or some of the people who have like this tiny lacunar infarct that affects the connection between the both hemispheres. So absolute exclusion criteria, if you have a clear cerebellar function, especially in the early stage. Somebody like finger to nose, he has dysmetria, like you look for the eye, they have like a gaze evoked nystagmus. They have like also balance issues with the gait. So you think it's not idiopathic. If it is something, it's a Parkinson plus, it's a multiple system atrophy. If you look at the patient, if he's able to look down, you just ask him to open the eyes and follow your finger down. If they are not able to go down, like the vertical gaze, then you think it's a Parkinson plus. If it's there, also just do the saccade. Saccadic means like a fast movement, up and down, up and down. And you see that once they go down, they stop in the middle, they don't go lower. That's also a Parkinson plus. So probable, it's okay if you have like a frontotemporal type dementia developing in the patient, of course, it's another thing. And so if you have yes, one thing, it's really a big issue is like in all the referrals, or so many of the referrals, that the patient has slowing only in his lower extremities, which we call it a lower body Parkinsonism. which is like a vascular type of thing. But I will explain to them what the challenging came recently. And also treatment within the past year with some of the dopamine blocking, like antipsychotic, antiemetic. If people took this treatment, even if you are having unilateral, this is good, like a plan of management also to stop it, because sometimes this may unmask the potential of Parkinson's disease. So response, okay. Then the other ones, if you are building up the levodopa in a patient with a Parkinson's disease and you almost reach 1.5 gram, like 1,500 milligram, and there is no response, or they have like side effects and with no benefit, then you think of alternative, like multiple system atrophy, like progressive supranuclear palsy, etc. So one more thing that is, I always emphasize that the people will, when they check the neurological exam for normal neurology type thing, they just check for the peripherally type of sensation. We have something called the cortical sensation. And these are the 2-point discrimination, graphesthesia when write a number in the hands or something like that, or recognizing things when the eyes close, we call it stregnosis. These are the things that we look for if they are affected, because usually they could be affected with normal pinprick temperature and the normal sensation what we do. And also if you have a normal functioning neuroimaging for presynaptic dopamine, the DAT scan. If you do a DAT scan on a patient, which is one of the studies that we are using these days to confirm or to differentiate between essential tremor and Parkinson's disease, if it is normal, then it should raise the suspicion that it's not Parkinson's disease. These are absolute exclusion criteria. So investigation, actually, we alluded to it while we are going through. We talked about the clinical diagnosis. We talked about that under the 50 years, you have Wilson disease and genetic, CT and MRI for structural lesion, PET and SPECT scan, and that scan we said, and olfactory, we said it's an early type and simple, easy type of test to do. Differential diagnosis, we alluded to some of them. Again, we said you have the mnemonic. Be careful if the P is coming in the front, like it's like a postural stability. If the tremor is bilateral, etc. And these are the things. If they have like not akinesia, they have the dystonia type of things. So one of the things we said, it's drug-induced Parkinsonism, and the other one is vascular Parkinson, that most people are used to attribute it to the lower body. Upper limbs are okay, he's only slow. So then Lewy body dementia or idiopathic Parkinson disease. Lewy body, you know that the cognition changes frequently in 24 hours. And they have this postural instability and falls early in the disease. And they have this sensitivity to neuroleptics. You give them something to stabilize and they have like sensitivity to it. If you know it's an idiopathic Parkinson disease, then it's your job to know if it's like a Parkinson plus or not. This is one more slide because for the sake of time, we have to go through it. So one more thing, why I have to emphasize on this one and take a few more minutes, because it's really so many referrals comes that it's like, and it's like any type of patient, they have a white matter changes, like little bit like vascular, and Qatar, it's common, like it's very common in Qatar, like you see high blood pressure, diabetes, and these things, and they have these white matter dots all over, and they have like a slowing in the lower limb, and they say they labeled it as a vascular Parkinsonism. So we found that there is no correlation with that. So the only thing that you find that it's really related, a definite vascular Parkinsonism is the considered result. What we saw ischemic and hemorrhagic when we affect the substantia nigra, in the substantia nigra or the pathway going it, but assuring that the striatum is not involved. So I will show you some of the MRIs that happens and CTs, and there was no Parkinson's disease. So my point from this slide, white matter changes we see commonly in Qatar cannot be blamed for vascular dementia, and always keep in mind to look for a differential diagnosis. So many cases reported as vascular Parkinson may represent PSP, for example, progressive supranuclear palsy. You have to just follow them up. Or vascular pseudo-Parkinsonism, like for example, somebody has bilateral mesial frontal stroke. These are small vessels, and they have diabetes and hypertension for a long time, and they affect these small vessels, and they will be a kinetic mute. And these people will be diagnosed as a vascular. They are not. Or you have apathic depression. Sometimes it's also diagnosed as a Parkinson. Then there is something called a pseudo-vascular pseudo-Parkinsonism. It's like a normal pressure hydrocephalus. So this is designed as we say, like, we look at the image, we see the ventricles are dilated. So we have to keep in mind these differential diagnoses, not always. Only one strategic, which we showed you at the beginning of the second slide, that if it's affecting the Niagara striatal pathway or the substantia nigra, this area in the midbrain, then this is the one could give you Parkinson disease. So most common cause of lower body, yeah, most common cause, it's like we said, the onset, if midbrain stroke and hemorrhage we talked about. The other ones, always you have to think of differential diagnosis. Some of them, it's really crucial to keep in mind. If you see that temporal lobe was having like some white matter changes, always keep in mind, especially in a younger like 40, 50 type of years of old, there is a cadazale, it's an autosomal dominant. So there is meningite hydrocephalus we talked about, NPH also we talked about. And if you have lower body Parkinson's plus falls, unremarkable MRI, it could think of this as an early progressive superior nuclear palsy. It's a Parkinson plus syndrome. Keep it in mind, think about it, or follow the patient up. So again, if you have some other features that could not be explained, is there is a frontal lobe lesion like akinesia, apolia, that's not interactive or apathic or depressive. So, and with lower limb, also do MRI, look for any other causes that giving these features. Interesting, I found this article that shows like several types of like a stroke happened, or like there is subdural, there is like all, as you see that they involve almost every part of the brain, and they followed them up. None of these patients develop Parkinsonism. So meaning to say vascular Parkinsonism now these days is not accepted. So it's, you have to have like a really pathological one. So clinical features common, okay, in NPH, normal pressure hydrocephalus and vascular Parkinsonism, reduced gait velocity, stride length, they will take a step smaller, diminished step height, and freezing of gait, magnetic feet that they glue to the ground, a preserved arm swing. This is one of the things that you differentiate Parkinson from. Like they will be very hardly walking from the lower extreme, but the arm swing up is there. But in Parkinson arm swing, the first thing will be affected. So poor response to external cue, upright posture, they will be like a cautious type like thing. Poor response to levodopa. No matter what you give, they don't respond. And I said, none of these have been studied with pathological correlation. One more thing that they thought it's a unique to normal pressure hydrocephalus. As I told you, it's a broad base that's separated and with outwardly rotated feet. So the feet are like this, rotated outside and broad. So if you see like the patient's going like a very like a step by step, this is with the features of the MRI. Don't blame it on the vascular. Please think of normal pressure. Why? Because normal pressure hydrocephalus treatable by relieving the pressure of the brain, like removing CSF and putting a specific screw or needle to keep like draining, or sometimes shunting, and they do response. And I have a patient from Jordan who's like running a company now after the shunt. Management will not take long in the management. Regular exercise for sure, cycling for definitely. And so, and then would come like the dopaminergic treatment. We have something called the honeymoon. And it's not, this is the time the patient start to switch doctors. Why? Because he used to get a very good response without the side effects. Anytime the line goes above here, you will have extra movement. What do you mean by extra movement? The patient will be like rocking around. It's not like so. And once, anytime he comes below the line, he will be like a stiff sitting like this. So he will do what you do, like he will take like more of the doses. Here, if the patient is younger than 65, we used to in the past to start with the dopamine agonist type of thing. If it's older, we take like a levodopa. These days, no, we don't respect that. We'll start immediately with a levodopa carbidopa. Once we hit this area, we are going this one, we need something like a prolonged acting. We add some of the COMT inhibitor type of treatment to prolong the acting. We could also add a dopamine agonist long act to smoothen the response here at this period. We could also make the doses smaller so they don't go higher up, and more frequent so they could cover this area. And as you see, as they go further, this area of like side effects is going more. He will be more akinetic. This is the progression of the disease. It has nothing to do with the treatment. This is the time that you have to look for an advanced type of treatment. Luckily, recently, we have some approval of inhaler. If you didn't hear about it, please, if you have patient for Parkinson disease, we have inhalers, and they are proven to help with these off times, and they are faster. They don't need to take time to kick in. We have also the sub-Q injections of apomorphine. It's the name only, apomorphine. It has like some side effects, but it could be taken up to 5 times. When do we use it? If the patient is planning to go out with a family or doing some activity and he needs a rapid response, he will inject sub-Q under the skin some of this apomorphine. He will be up and around. And sometimes also they do it and they put in a pump type of thing, continuous, if they need it more than 5 times. And as I mentioned, this now it's in a progress also. It still should have been out like a long time ago, but at some delay, that sublingual apomorphine also. It's there that the patient could put under the tongue. He will be active for 1 or 2 hours. He could go do his shopping and come back. So, and this is the difference between the pump and this one. And this slide, it's a little bit lengthy one. It's when we kick in what we call a duodopa or a duodenal levodopa. It's a special levodopa. It's the same levodopa, but it's a gel, and we inject it through a line in the stomach. We put a tube below the stomach and then in the duodenum, and then we infuse. And there's a machine will calculate if he needs 600 milligram a day. The machine will calculate it for the patient. All what the patient should do, wake up in the morning, fix the machine and press the button. And it will deliver throughout the day. And it will, these are the ones like when the patient has unpredictable off time and unpredictable dyskinesia and it's bothering him. So the DBS is also another option. As you see, we choose between cases, which one will go. For example, if somebody has dementia or severe dementia, nothing. If he has a mild dementia, still we could consider. There's a green light for like some like duodopa. There is a yellow line for apomorphine pump. If there is psychosis, we have to judge and we have to sit in a multidisciplinary to discuss what he may benefit from it or not. And if you have, for example, no social support or something, it will be less. And there I have like a patient who wants to and to be independent. Again, he's coming early in the disease. He's not indicated green or he's not contraindicated, but he wants to be independent. And I've seen cases, especially in Germany, that they do implant, and for the cost effectiveness end of the year, it's much better for the country as well. And by that, I hope it was not too long for you. Thank you very much. And I will be happy to answer some or the few questions. Sadly, because of the restriction of the rooms during this pandemic, I will not be able to spend more time because the patients are waiting at 11 for the test.
Thank you, Dr. Adeli. I speak for all the attendees. Really enjoyed your talk and very stimulating. I have a couple of questions from the audience, but maybe I'll kick off a little bit. And you talked about treatments, and I guess my question is how is progress being made with respect to slowing the progression of the disease down? Because what's behind my question is, you know, we thinking about genetics and the environment and genetic interactions, you know, we're thinking about, can we sort of early, even before we see clinical symptoms, have a pre-symptomatic diagnosis? And can we intervene early to recognize that this might progress and slow down the progression? So what's happening on slowing down the progression? And do you think it's feasible that we could have almost a genetic counseling concept to identify people who should be, you know, both paying quite close attention and maybe are already doing something prophylactically?
Yes, actually in the Hamad University, we started some and we gave some of the family and we talked to them and they accepted to come for earlier diagnosis even before the symptoms. And as we mentioned in one of the slides, you are losing almost 60% of the substantia nigra compacta before having the motor symptoms. So what if like we need to do any prophylaxis? Even the rasagiline, which we are using, is not like a very strong result or something, but we are using it late. So if we know things, and if we have some things like to discover it early, like what the Hamad University discovered, that's a GABI, it's the blood test, but it needed to be validated with and used with the patient a bigger number. Of course, definitely, if you find a way to diagnose these cases earlier, for sure, because you're preventing the death of these cells. And
Correct.
I have patients also clinically for like almost like 12 years now on rasagiline, and they are much happier. Although they are like diagnosed after the motor response. I mean, the motor response is kicked in, and then we started rasagiline, which is claimed or like said to be protective. And recently in Germany, some of the studies are even saying, even if you do for younger generation, if you do deep brain stimulation, also gives you like a protective type. They have their own study, but I had no time to review it, to go over it. Because we do not, and most of our patients here do not prefer to go for surgery. They will like to leave it for very late.
So there's a question from the audience who was asking from Noor. She noticed that you talked about these cognitive decline in certain PD. So she's wondering, how often do you see that, and is that, you know, a distinct phenotype with the cognitive decline? How common is that?
Actually, as I said, it's a specific type. It's a frontal life executive type, making decision. And this is one of the things we face, and the patient will tell the doctors, I need this medicine. It was in that, like, they cannot even make decisions for their own treatment. They choose for the stage which is wrong and what used to help them. And they don't realize that they are going in the progression of the disease, and that's the time that they have to use another type of treatment. So it's executive function, decision making, deciding where this is, and anxiety and depression, etc. Like this is like a cognitive, but actual memory type of thing or frontal behavior or something. And if it's a florid and in the beginning few years, then it should raise a red flag that we are dealing with something else, and we have to investigate for another association, like one of the frontotemporal type of dementia that they present with Parkinsonism as a presentation. And that will take us again to the first line of that. We said it's a unilateral, it's asymmetrical in Parkinson, idiopathic Parkinson disease.
I'm going to combine a couple of questions that are related, you know, which is, you know, you kind of brought up, you know, all these different, you know, differential diagnoses, you know, which are getting complicated, and you're trying to distinguish Parkinson's from Parkinson's plus and prefrontal dementia. What's the progress on beginning to use machine learning algorithms and things like that to really, you know, make this, you know, taking this more, I don't know if objectively is the right word, but can you apply those sorts of tools to improve the calling of this disease?
The tools for like tremor measurement and tremor study?
I think that's what's in the question. How I mean, it's so complicated. You might
I know
think
it's
about
a good one. I saw it in King's College in England. They are using it. It's a quite really helpful. It will ease our job. Like I would really love if we can get it, but we need assistance, like employing people to use it, because they need technologists. Of course, this will tell you and give you more like information, like if it's more of a rest tremor. For me, no. For me, here in my practice, I will base it all on my specific examination, like to distract the patient to see it's a rest tremor, it's like a re-emergent tremor. But definitely, if the question, those tools of definitely they will help. Yes, they will show you.
Somebody was asking about is PD prevalent in people who are athletic? Is there some sort of you know, association or lack of?
In my search, I did not find any conclusive type of things. Like some of reports, even the head trauma also. There's an association. We saw people, but there are so many others who have it and they did not ever had any type of head trauma. So yeah, as a conclusive result, I cannot say yes, no.
But are athletic people more likely to avoid getting PD?
Yes, yes. Avoid, yes. The more active. Why I say that? Because the more, like most of my patients who can exercise, they have better response even to treatment, or who accept. Those who like to have like sedentary life, they go to the worst part.
As long as their athletics is not boxing, I think that's a good thing.
Yes.
Right? So there's a couple of thoughts there, and some of the questions is kind of the link between, you know, metabolic diseases and neurological disorders. So, you know, maybe you can comment a little bit on particularly, you know, diabetic links to PD. Is there anything that you can comment on there?
There is a very weak association that people who are diabetic, again, goes to the same question you already said before, the exercise or athletic or healthy life. If you have a healthy life and healthy eating and these things and the good antioxidant, like eating from natural source or something, yes. But again, this association is not strong. There is some association with it, but it's presumed. It's one of the stimulant for people to be active.
Right. Maybe I'll just, because we're getting close to 11, maybe just wrap up. I know there's some talk about the odorants, some detection of smells from PD patients. I don't see that in your talk. Is that something you're buying into, or what?
No, anosmia. I didn't put the picture, but I mentioned it in the beginning of the talk. Yes, anosmia is one of the signs. Actually, it's not only for Parkinson disease. Even if a member, I
wasn't talking about the ability of the patient to smell, but I know that there's some thought that you can detect PD by the scent emitted from the patient.
But they will not say I don't smell. They will say I don't taste the food well. things are not like it's a salt is a salt, but it's not the same. It's like sugar is sugar, but does not taste the same. Or the flavor of, we use here in Qatar so many flavors or something. They say the food does not taste the same, and that's the time I go and test for olfactory.
But I
And
heard
as
that,
I told you,
some clinicians can smell the patient. They can smell their arm and recognize whether they're having Parkinson's. So I know it's a bit controversial, and that likes to get into the press. I just didn't know
I
if
have
you had
very
any comment.
simplistic type of things. Smell, I have them like prepared, but there are certain sophisticated type of shields and these things that are really useful and being used in so many centers in the US, especially Mayo Clinic.
Well, we
But
should let you go, and we
I
should
just
let
copied them in a very simple way.
Yeah. Well, Dr. Gallen, we really appreciate you taking the time to give us a very thorough education on Parkinson's disease and movement disorders in general. I don't want to hold you up because I know you have to release that room. So thank you once again.
I thank you,
to all the
actually. Thank
audience.
you very much for having me. Thank you. Anytime.
Our
Thank you.
pleasure. Okay,
Bye-bye.
take care.